Morning. My name is Asha Thomas, and starting with the ANP topic of clinical presentation, abdominal paracentesis. Introduction. Abdominal paracentesis is a safe and effective diagnostic and therapeutic procedure used in the evaluation of a variety of abdominal problems including ascites, abdominal injury, acute abdominal and peritonitis. Ascites may be recognized on physical examination as abdominal distension and the presence of a fluid wave. Therapeutic paracentesis is employed to relieve respiratory difficulty due to increased intra-abdominal pressure caused by ascites. Midline and lateral approaches can be used for paracentesis, with the left lateral technique most commonly employed. The left lateral approach avoids air-filled bowl that usually floats in the ascitic fluid. The patient is placed in the supine position and slightly rotated to the site of the procedure to further minimize the risk of perforation during paracentesis. Because the cecum is relatively fixed on the right side, the left lateral approach is most commonly used. Most ascitic fluid reaccumulates rapidly. Some experts recommend that no more than 1.5 liter of fluid must be removed in a single procedure. Patients with severe hypoproteinemia may lose additional albumin into reaccumulations of ascites fluid and develop acute hypotension and heart failure. Cancer patients with malignant effusions may also need repetitive therapeutic paracentesis. Intravenous fluid and vascular volume support may be required in this patient if larger volume are removed. After diagnostic paracentesis, fluid should be sent to the laboratory for gram stain culture, cytology, protein, glucose and lactate dehydrogenase levels, and blood cell count with a differential cell count. A polymer nuclear cell count of less than 500 cells per mm³ is highly suggestive of bacterial peritonitis. An elevated peritoneal fluid amylase level or a level greater than the serum amylase level is found in pancreatitis. Grossly bloody fluid in the abdomen, more than 1 lakh red blood cells per mm³, indicates more severe trauma or perforation of the abdominal organ. The classic positive test for hemoperitoneum is the inavailability of type through the paracentesis lavage fluid. Definition. Abdominal paracentesis is a bedside clinical procedure in which needle is inserted into the peritoneal cavity and ascites fluid is removed. Now, types of peritoneal fluid drainage. First is for diagnostic. Small quantity of fluid is removed for testing. Second, therapeutic. More than 5 liters of fluid is removed to reduce intra-abdominal pressure and relieve the associated symptoms like dyspnea, abdominal pain. Indications for evaluation of new onset of ascites, testing of ascites fluid, for evaluation of patient with the ascitic who has clinical signs of deterioration like fever, abdominal pain, hepatic encephalopathy, decreased renal function and metabolic acidosis. Paracentesis can identify unexpected diagnoses such as hemorrhagic or eosinophilic ascites. Useful to know etiology and antibiotic susceptibility. Equipment. Disposable paracentesis or thoracentesis kit usually include the following: aseptic swab test, fenestrated drape, lignocaine 1%, 5 ml ampule, syringe 10 ml, 2-inch long needle injection, number 11 blade scalpel, 14 gauge catheter over 17 gauge into 6-inch needle in with 3-way stopcock or 1-way valve, self-sealing valve or 5 ml Luker lock valve syringe. syringe of 60 ml, tubing set with roller clamp, drainage bag or vacuum container, specimen vials or collection bottles number 3, gauze 4-inch adhesive dressing. Now indications. Evaluation of ascites fluid to help determine etiology, to differentiate transudate versus exudate, to detect the presence of cancerous cells or to address other considerations. Evaluation of blunt or penetrating abdominal injury, relief of respiratory distress due to increased intra-abdominal pressure, evaluation of acute abdomen, evaluation of acute or spontaneous peritonitis, evaluation of acute peritonitis, evaluation of acute pancreatitis, contraindications, acute abdomen requiring immediate surgery, severe thrombocytopenia, coagulopathy. In patients without clinical evidence of active bleeding, routine labs such as prothrombin time, PT, activated partial thromboplastin time, and platelet counts may not be needed prior to the procedure. Severe bowel distension, multiple previous abdominal operations, pregnancy absolute to midline procedure, distended bladder that cannot be emptied with a Foley's catheter, obvious infection at the intended site of insertion, severe hypoproteinemia, intra-abdominal incisions, massive ileus with bowel distension, primary fibrinolysis, patient with disseminated intravascular coagulation. The procedure. Patient preparation. Explain the procedure and obtain consent. No fasting before procedure. Position. Mostly supine, head may be elevated, knee-elbow position for removal of minimum fluid in the dependent area. Equipment at staff, doctor and assistant. Bottles should be labeled for test prior doing paracentesis. Site, lower left quadrant, which feels dullness on percussion, 3 cm medial and 2 cm above the anterior superior iliac spine, not near umbilicus because the presence of collateral vessels, surgical scars and visible veins should be avoided. Step 1. Mark the site as X and position 12, 3, 6, 8 a few centimeters from X. The insertion site may be midline or through an oblique transversus muscle which is lateral to the thicker rectus abdominalis muscles. Step 2. Empty the patient's bladder either voluntarily or with a Foley's catheter. Place the patient in the horizontal supine position and tilt the patient slightly to the side of the collection, usually the left lower quadrant. Slightly rotate the hip down on the table on the site of the needle insertion to make that quadrant of the abdomen more dependent. The insertion sites will be much clearer. Step 3 is prepare the skin with povidone iodine or chlorhexidine solution and allow it to dry while applying sterile gloves and a mask. Pearl. Prepare a white area so that the undraped area is not inadvertently exposed if the drape slides a little. Step 4. Center the sterile drape about 1/3 of the distance from the umbilicus to the anterior iliac crest. Step 5. Local anesthesia. Infiltrate the skin and subcutaneous tissue with a 1% solution of lignocaine with epinephrine. A 2-inch needle is inserted perpendicular to the skin to infiltrate the deeper tissues and peritoneum with anesthetic. Step 3. Insert the catheter or introducer through the skin, the non-dominant hand that stretches the skin to one side of the puncture side, and the needle is further inserted to create a Z-track using 3 to 5 ml of 1% lignocaine solution in a Z-track technique. Needle for it is 1.5 inch, which is sufficiently long. Insert the needle and syringe 5 mm deep. Pull the plunger back with each advancement to see if any blood is aspirated. Inject the lignocaine gel solution. Continue the same procedure until the needle enters fluid. Aspiration should be intermittent, not continuous. If continuous, it maple the bowl for omentum on 2 needle tips, occluding the tip. Yellow color fluid indicates needle is in peritoneal cavity. Step 7. Advance the catheter until a pop is felt and the catheter penetrates the peritoneum. Release the pressure on the skin after the introducer enters the peritoneum. Now advance the catheter into the abdominal cavity. Now step 8. Remove the introducer and attach the syringe. Draw the fluid into the syringe. If no fluid returns, rotate slightly, withdraw or advance the catheter until fluid is obtained. If still no fluid returns, abort the procedure and try an alternative site or method. Ascites fluid may be removed by attaching the 3-way stopcock or 1-way valve, a 60 cc syringe to the arm and drainage tubing and back to the other arm. If lavage is desired, such as for detecting hemoperitoneum after trauma, connect intravenous tubing to the 3-way stopcock, remove excess fluid and then re-infuse 700 to 1000 ml of Ringal lactate or normal solution into the abdominal cavity. Gently roll the patient from side to side, then remove the fluid as described using a tap suction arrangement. Rotate the needle in for 90 degrees or more will pierce the peritoneum and help the drainage. Now step 9. After the procedure, gently remove the catheter and apply direct pressure to the wound. Observe the characteristics of the fluid and send it for the appropriate studies. If the insertion site is still leaking fluid after 5 minutes of direct pressure, suture the site with vertical mattress suture. Apply a pressure dressing. Initiating flow of fluid. Small amount of fluid may be difficult to drain because omentum or bowl may be blocked at the end of the needle. So multi-hole needles are helpful. Testing. 25 ml fluid is enough for cell count, differential count, chemical testing and bacterial culture. 50 ml of smear and culture. Pitfall. Gauze dressing should be applied when rare, persistent drainage occurs. Now the complications. Abdominal radiograph should be obtained before paracentesis because air may be introduced during the procedure and may interfere with interruption. Next is the perforation of bladder and stomach, emptied prior to the procedure to decrease the risk. Bowel perforation, laceration of the major blood vessels, loss of catheter or guide wire in the peritoneal cavity, abdominal wall hematomas, pneumoperitoneum, bleeding, perforation of the pregnant uterus, catheter residue broken into abdominal wall, infection, persistent leak from the puncture site, post-paracentesis hypotension, dilutional hyponatremia, post-procedure instructions. The patient should be instructed to monitor the bleeding of the area and return if any abdominal bleeding is noted. The patient should also be educated to call with questions, concerns regarding pain, numbness or discomfort in the area. The patient should also monitor for evidence of infection. Lastly, the patient should be advised to clean the area with warm soap and water and pat the area dry.